直接讲，OK，好，谢谢。Hi，可能大家还在吃点心。My name is YenLin Chen. Again, I'm from the Department of Radiation Oncology, Sarcoma Service at the Mass General Hospital. So today I'm going to switch gears a bit from sarcoma and talk about current state of cardiac arrhythmia ablation therapy, preclinical emerging early clinical evidence. So the outline is I'll define the clinical problem and what we have in the way of in vivo preclinical evidence and the early clinical trials to date. And as I mentioned, on workflow and what we know about cardiac OARs and radiation cardiac toxicity. And lastly, a bit about some of the unsolved problems for cardiac radiation, such as gating, double gating. So disclosure is that I am going to describe off-label use of linear accelerator outside of approved indications because this is a brand new potential indication but not yet approved. All right, so the 2017 publication of the first clinical series of off-label experience on non-invasive cardiac radiation for the ablation of VT in the New England Journal of Medicine ignited tremendous interest in this potential novel, non-invasive technique to treat refractory arrhythmia. And there are a number of trials in the pipeline around the world, US around the world, and here in Asia. So let's review the preclinical and early clinical evidence to date and some of the current challenges that still remain. So the clinical problem is that sudden cardiac events occur in 200,000 to 400,000 individuals per year in the US. Of those, 30,000 to 15,000 survive, and if observed, about 40 to 50% patients survive, less so for the patients who have an event unobserved. And then of those, about 15,000 per year, up to 800,000, to 200,000 undergo ICD implant to treat the recurrent VT. And of those, about 33,000 recurred by a median of 3 years. And of those, 20 to 30 undergo repeat catheter-based RF ablation, with a success rate ranging from 40 to 80%. So that leaves somewhere around 10 to 20,000 patients who need either another catheter ablation or other procedures, or go on double antiarrhythmic, and that leaves an opportunity for potential radioablation. So what is the actual target, regardless modality, for arrhythmia? The target is typically for VT, post-myocardial infarction-related scar, and much less commonly congenital. And for AF, abnormal pulmonary vein triggers. Catheter radiofrequency ablation and cryoablation are used actually very frequently, but with unfortunately high failure rate, up to 50% or greater. The mechanism of failure include inadequate heating, with scar causing other electrical activity for AF, pulmonary vein reconnection. And then if there's proximity to critical tissue like the sinus or AV node, esophagus, phrenic nerve, coronary arteries, those can create real serious and immediate complications. And then there are inaccessible locations such as deep endocardial areas of myocardium where the epicardial RF and cryo just simply would not reach. The alternatives for these deep targets include alcohol ablation, needle ablation, bipolar ablation. But these are all even more invasive and challenging. So what are some at least theoretical and also real differences between catheter ablation and cardiac radio ablation, or CRA, as it's now more popularly being called? So the energy used for catheter ablation, RFA, cryo, or the deeper ones, alcohol needle, versus, of course, using ionizing radiation, SBRT, a modality that we know well from lung cancer and treatment of metastasis. The pathophysiology for catheter ablation typically is heating or freezing, causing necrosis, of that tissue, and then changing the entry or exit points of the arrhythmia. For cardiac radioablation, though, it's I think we're still pretty early in that, but at least the initial hypothesized mechanism is microvascular injury, fibrosis, or some conduction changes. The timing to induce the lesion for catheter ablation is seconds to minutes, and for cardiac radioablation, it can be as early as a few days, sometimes a few months. but generally takes longer than catheter ablation. The targetable tissue for a catheter generally is in the tissue in direct contact or close to catheter. The deeper ones may be inaccessible, require more invasive techniques. And really for radioablation, really any tissue, given the limits of the abutting OAR, but really there isn't as much of a limitation as what can be reached. The geometry of the lesion for catheter typically a point or planar, whereas for catheter for cardiac radioablation, it's three-dimensional, where one would say even 4D, but it's volumetric. The potential benefits of catheter ablation is well established, but there's high recurrence or refractory rate. There's the benefit of near immediate effect for the patient, so being able to then reduce her ICD events and pacing events. For STAR, for cardiac radioablation, the benefit is it's non-invasive and can reach deeper targets. And the risk, of course, for catheter ablation is that's invasive. There can be risks of perforation. There's early mortality. And for radiation, too, there is a potential for radiation injury. So the proposed mechanism, as I mentioned, for cardiac radioablation include potential altered conduction or immediate inflammation, mitochondrial dysfunction, microvascular dysfunction, or an actual fibrosis. And we'll talk about the data that shows it's actually interesting. It might not be fibrosis that is necessary for it. So some of the earliest data comes from like the 2012, 2014. Like this is a study where mini pig models were treated 17.5 to 35 gray using just one animal per dose with photons to the right superior pulmonary vein antrum in an attempt to kind of simulate treating atrial fibrillation. They noted transmural scarring with doses greater than 32 gray at 6 months after treatment, and the 50% effective dose for intense fibrosis was 31.3 gray. And so you can see here the trichrome staining for sham radiation, and then after 25 gray, kind of the fibrosis, which is this kind of reddish material, the bluish material right here, and then the 30.2, more significant intense fibrosis. And this is a study from 2016, where carbon ion, this was conducted in Heidelberg, Germany, where rabbit models and also eventually pig models were used to target with carbon ion. Pencil beam, the ECG, the animals were continuously monitored with an ECG, and they were scanned with a PET CT within 20 minutes of radiation to detect a beta emitter byproduct. And they found that all the hearts treated, and they used very high doses, still remain in after treatment, all remaining sinus rhythm. So there wasn't any acute blocking during treatment, but after treatment, they did find that there was complete heart block when you escalate dose after 160 gray, and at 90 gray, there was diminished and kind of prolongation, type 2 AV block from 120 milliseconds to 440 milliseconds. And the PET CT showed beta activity corresponding to the plan. They did not see any macroscopic changes, but they did see very high gamma H2 AX signal in the radiation field. So very interesting study on carbon ion to ablate the AV junction. So of course we wouldn't use those type of doses normally, but they wanted to, as a proof of concept, that you can completely block the AV node. So this again was conducted by a very talented young cardiologist, currently in fellowship actually, who did a number of years of work in Department of Radiation before becoming a cardiologist. So Dr. Lehman. Looking at carbon ion ablation of various sites. Here's an example of targeting a right atrial kind of pulmonary vein target, and showing a decrease in the decrease in the lesions, and then here's the actual fibrosis that I was seeing afterwards. Here are examples of using carbon ion for AV junction ablation, for right superior pulmonary vein, left atrial junction ablation. And then what we found was that when you, again, do trichome staining, you can see increasing fibrosis at 3 months, at 6 months with increasing doses of radiation. So 25, 40, 55 gray, and the corresponding changes with apoptosis. And these animals were also monitored for weight changes and LVEF changes. And when you found out with carbon ion, there was very focused. The lesions were quite focused, and so there was really no significant changes in the LVEF or basic cardiac function. While the animals were alive before they were sacrificed for the histological studies. All right, and this is again another example of here the pig study where ablation with a planning, and then subsequently showing the myocardial injury, and after 25 gray of radiation. All right, so Dr. Holman and others in 2019 did this series of studies using domestic pig models with protons, 40 gray at one side, 30 gray at two sides, or 40 gray at three sides of the left ventricle, and they looked at the tissue. For the hearts treated with less than 20 gray, really had a really normal growth and microscopic appearance, but with 20 to 30 gray, there was increase in fibrosis, and with greater than 30 gray, there was frank necrosis and myocytolysis with vacuolar degeneration. This study by Dr. Rapp and others in 2019 using a pig model with carbon ions. Here we go. Doses ranging from 25 gray to 55 gray to the AV junction. Oh, I think I keep hitting the wrong thing. Sorry about that. Also showed a dose-dependent increase in fibrosis at 6 months after radiation. So here's a nice 2020 review by Dr. Van der Ree and others, and published in Heart Rhythm 2020 of 13 preclinical studies in 218 animals, including rabbits, dog, mini pig, larger pig, using doses ranging from 5 to 160 gray in single fraction. 80% of the animals received RT, and about 20% were controls. A mixture of photon, carbon ion, and just one study with proton. What they showed was that radiation-induced changes in electrophysiological properties. And for the 13 studies, I looked for it. All the 4 studies show greater than 80% EP parameter reduction after 20 to 55 gray of photon or carbon ion. RT-induced AV conduction changes in the 6 studies I looked at it, where greater than 2/3 of the animal in most of these studies had AV block. And RT greatly improved conductivity in 3 studies where they looked at animals after induced MI, so by injecting microspheres, creating actual MI, and then radiating with 15 gray. 2 weeks later, they actually found improved conductivity and decreased vulnerability of the heart to VT after MI. So some very intriguing data from the lower doses. All right, so the first in-human study for VT was treated by Dr. Billy Liu and others out at in California, reported here as a case report in 2015. 71-year-old gentleman with coronary artery disease, has CABG with low EF, and has ICD-4 VT that was refractory to dual antiarrhythmic therapy for 2 years. And he had VT 160 with rapid right bundle block, and mapping using PET showed a hypermetabolic scar in the left ventricle involving the inferior inferoseptal walls. So he used a CyberHeart plan and treated with 25 gray ×1 with Accurate and CyberKnife, normalized to 75% isodose lying, and it took 90 minutes to deliver. So temporary pacing wires were placed as a fiducial for respiratory tracking, and then he estimated cardiac motion with fluoro. The patient did have transient benefit for about 7 months, after which he did eventually die of his originally already poor heart failure. So coming back to the study published by Phil Kuklich and others at WashU in 2017 in New England Journal of Medicine. The candidates, of 5 candidates treated in this off-label study, were patients who had failed prior conventional catheter ablation and not candidates for repeat catheter ablation, and have a defined anatomic substrate, a rhythmogenic focus that could be targeted. Patients were treated with 25 grade times 1, and you can see on the right side they underwent EP mapping and had MRI and SPECT scan to define the lesion, which were contoured collaboratively, surgeon and electrophysiologist. And then patient was positioned with breath hold control, and then here you can see the alignment on the cone beam and treatment. So what they found was 6 weeks post-treatment, all 4 surviving patients, there was a patient who had, they thought kind of not clear if it was related or pulmonary edema, but there were 4 surviving patients who were able to discontinue antiarrhythmic medication. There was a patient who did eventually restart amiodarone, and a patient who did eventually undergo catheter reablation because of incomplete cessation of his VT, but he had no further episodes by 12 months. And like you can see here, the benefit actually occurred fairly early on. So here you see the number of VT events. In fact, some of these were kind of, at the peak, at the time of treatment, and fairly rapid reduction, within 1 to 2 months after the treatment. So early and very dramatic responses. So the WashU group then went on to conduct a phase 1/2 trial of the cardiac radioablation for VT. They had an initial report at 16 patients, but actually they just published this with 19 patients enrolled, and this was published in Circulation, where 17 were for VT, 2 for PVC from cardiomyopathy, and 10% of patients developed severe adverse events. The VT events were reduced from 119, ranging from 4 to 292, down to 3. Ranging from 0 to 32, with significant p-value. They had the reduction were in both reduced ICD shocks and also reduced pacing. The VT burden overall was reduced by 75% in nearly 90% of the patients, and at 6 months, the overall survival was 89%. The use of dual antiarrhythmic, the antiarrhythmic drugs have a lot of potential complication side effects, and so the use of dual antiarrhythmic reduced from 59% down to 12%, so very significant. Quality of life, which was only surveyed in 9 patients, did improve at 6 months. Now, subsequent to that, there's been significant a good number of studies that's increasing exponentially by the year that shows again very effective with 25 grade times 1 reduction in VT events. So very consistent. In this plot, these are the pre number of ICD shocks and post. So very dramatic. But the problem is that there are potential complications. Well, not potential complication. There are late recurrences. The authors that go on and report, this was reported in the Heart Rhythm Society in 2021, and then again by Dr. Robinson at ASTRO 2020, a non-randomized retrospective comparison of cardiac ablation, so catheter ablation patients versus patients who underwent radioablation. Both populations are patients with refractory VT after an initial catheter-based ablation. And so they compare the patients in terms of, they're very comparable in terms of their age and New York Heart Association class, the percent of VT storms and their EF. So, very similar parameters. And what they found was that there was clearly a difference between patients who underwent here at the top the radial ablation versus the catheter ablation. And freedom from shock and storm was essentially, it was almost identical between the two, which is quite remarkable for this brand new modality. 1 year freedom from shock and storm was 42.4% versus 45%. The overall survival, though, was different. So freedom from shock and storm, they're equally effective in terms of reducing the VT storms, but there was a difference. And why is that? And so what Dr. Robinson pointed out is that most of the catheter ablation death actually occurred quite early. And so looking at that in more detail, these were actually patients who died from acute complications within 0 day, 2 day, 5 days, so within just a few days of the procedure. Whereas the radiation ablated patients, it took longer to develop other events that affected. So immediate death from catheter-based ablation may account for most of the difference in terms of patient survival because they're equally effective in terms of freedom from shock or storm. All right, and very interesting, the WashU group has this very nice study on Nature Communication by one of their translational scientists looking at the mechanism, so cardioradiotherapy. And what they found is that it actually, instead of causing fibrosis, which is, it really takes longer, like months to induce, there were actually early electrical conduction reprogramming in these in these animals. Sorry, not animals, but in these patients. And so, sorry. I apologize. So this is actually an animal-based study, and so they looked at basically the genetic programming changes, and won't go into all of this in great detail, but it's a helpful study to look at. But there were changes in terms of the what's activated, and they suggest that maybe it doesn't require fibrosis. Maybe it's really just a conduction reprogramming that's necessary to explain the effect of radiation early on. All right, and so based on their phase 1-2 results, they have expanded their study to do a randomized phase 3 trial, multi-center perspective, multi-center registry trial, and randomized trial called redo catheter ablation, or randomized patients to redo catheter ablation versus radio ablation. And so the results of this will be highly anticipated in hopefully a couple of years. So the workflow. So basically the workflow, it is quite complex, and I think this is definitely worth a whole nother several talks, but it's important to identify the target using both what's called electrical sourcing and structural sourcing. So electrical sourcing can come from 12-lead EKG or ECG eye mapping to find the exit entrance sites, the foci of the part of the heart that has the VT rhythm. Prior mapping may or may not be helpful. So sometimes the VT refractory VT may be some time from the original catheter ablation. And then the structural sourcing is identifying a lesion on either CT or cardiac MRI, and in some cases, in the case of sarcoidosis, even using PET scan or SPECT to define a scar. And the target is not like a tumor target where you must treat all. It's must treat all in order to have a best chance of control. What you really want to do is target as define an exercise for VT in the scar. The whole scar is not necessary, and you want to try to avoid targeting healthy heart. And because it may not be easy to fuse ECGI due to breathing differences or differences in the various scans and heart sizes, and also just the non-planar, non-standard axial views that we're not used to seeing, and then the EPs are not used to seeing the usual standard axial planes. The WashU group recommend using the 17-segment model where based on the ECGI and imaging, you agree upon the segment of the myocardium that's involved and then defining that. And when they did a variability study, they found that using this model, the variation in that target definition between electrophysiologists is typically within one segment from another, as opposed to a much greater variability that they've demonstrated in other studies. And so this is an example of a patient treated with 25 gray using the 17-segment model. And seeing the reduction in the VT events. All right, so there's some exciting things being looked at, other targets for VT, such as denervation of autonomic ganglion for incessant VT, long QT syndromes, catecholaminergic polymorphic VT, or epicardial ganglion ablation. There are other potential targets that could potentially disrupt, the VT storm, and so be interesting to look at. So, is it, what do we know about the toxicity? Well, for most of radiation, we really try to avoid the heart. It's usually unintentional because of treating lung, esophageal, breast, lymphoma. That there is some dose to the heart. So really, our paradigm is to avoid radiation heart. So there are many studies over time looking at various parameters associated with coronary artery disease. For example, breast Hodgkin lymphoma treatment, radiation-associated coronary artery disease. Here's an example of stenosis from intimal proliferation years after lymphoma treatment, and other cardiac disease such as valvular heart disease, cardiomyopathy. Sorry, my cast keeps on hitting the wrong button here. Sorry. Cardiomyopathy, and there are different parameters. There are some nice reviews that summarize this vast amount of data on cardiac toxicity from late cardiotoxicity. But we also know from mostly esophageal and lung cancer that there are some more immediate toxicity associated, especially with the high doses. So not the lower dose exposure, pediatric cancer, lymphoma, but high exposure from treatment of thoracic malignancy. And these may be immediate pericarditis, pericardial edema, arrhythmia. So this is an example of radiation-associated pericardial effusion, and there are dosimetric parameters associated with with increased likelihood of these events to the whole heart or sub portions of the heart. So in interest of time, I'll skip those. Do we have any experience actually intentionally treating the heart? Well, we actually do, and this is kind of how I got into this. I was treating just these super rare cardiac sarcomas, and at MGH, where we might see like somewhere 5 to 10 cases a year. So these are just so extremely rare. But we have experienced intentionally treating the heart, for a malignancy that has such poor outcome. So extremely rare. Mostly angiosarcomas, mixed fibrosarcoma, a mixture of histologies that we now call intimal sarcoma, 25 cases a year. And these patients generally survive somewhere around 3 months to 12 months. Very few reports have patients surviving past 4 years. They do best with our R0 resection, but that's rarely possible. And there's just very complex motion. And so early on, various SBRT techniques, carbon ion have been tried. And so we've been treating these with about 52 as of 2017, but probably another dozen since then with proton therapy. So these patients have tumors located generally in the myocardium, involving a variety of subsites, ventricle, atrium, less commonly left ventricle, but often involving both right atrium, ventricle, in that AV groove, for example, for angiosarcoma, or the atrium for intimal sarcoma. So vast majority of these patients were treated with with radiation protons to high doses, around 64.5 median radiation dose, and mean heart dose was 17.5. And the mean left ventricle dose, fortunately, were quite low. So for right ventricle free wall tumors, right atrium, left atrium, the proton allowed us to keep the doses to the left ventricle down in the 1 to 5 range. If we're treating the right ventricle whole chamber, that's when we start to get more dose into the left ventricle. And then the occasional patient with left ventricle tumors, they really no choice but to treat those patients. So one problem we had to overcome was cardiac motion. So here's an example of how much movement there can be this between end diastole and end systole. So you see here 1.5 centimeter, between the two faces. And over time, we define respiratory motion using different modality. Very early on, we use echocardiogram and just adding vectors, in different directions, kind of roughly expanding in those. And then as cardiac MRI, I guess there must be a timer, and then cardiac MI became more commonly used. We shifted to that, but those were limited by the thick slab sizes, about 4 to 6 millimeters. So, and it takes a long time to obtain, very hard for patients to breath hold for any thinner slices. And then cardiac CT became more commonly used for coronary artery assessment and other structural assessment. And so we now use cardiac CT to define our integral, we call it integral cardiac volume. And most of our patients we did use respiratory gating when we were using 3D passive scattered protons. We were able to do respiratory gating. So this is a comparison between a VMAT plan and a proton plan. Here on the left, you see here with a VMAT plan, you can get fairly decent conformality of the high dose, but what you see is much higher intermediate dose to the rest of the heart, especially in this case, it's still difficult to keep the dose out of the left ventricle. And then you also see that the conformality comes at the expense of this dose path to the lungs. Whereas with proton, for this right ventricle lesion, you can use a single or occasionally, a double interior beam and really very rapid dose drop-off. So, in this case, you can actually, spare the left ventricle free wall even if the septum has to be treated. So here you see the difference between VMAT, the dotted line, and the solid line with proton in terms of dose for various organs. So here the whole heart dose is quite significantly different, and then here the coronary arteries also is much better spared with proton. So these were examples. So we began treating these patients, and we were able to control them, without really very significant heart block or drop in their EF. And so we were starting to see patients surviving 5 years, 8 years. I think my record is a patient who was 14 years out. Here an intimal sarcoma of the left atrium. You can see it right here, this lesion. And then this is from the passive day proton. So, right here, the full dose coming in, the top of it, and then, right, okay, sorry. Okay, and then here's a 40-year-old with synovial sarcoma of the left atrium with no evidence of disease at 7 years, but did develop oligometa 4 years that we ablated. So here we use 2 beams with no exodose here here you can see the left ventricle defined, or not no exodose, but limited, much more limited exodose. Here is someone with a right ventricular outflow tract intimal sarcoma. No local recurrence 5 years out, but yes, these patients often do develop metastasis, so that's the thing. But at least they're not dying of their primary disease, primary cardiac disease. And here's an example of a patient with an interatrial septum tumor, very nice and sharp proton plan, just the very lowest of the entrance dose that allowed optimization here, and a bit of esophagus sparing. So we didn't use just one single beam going through the esophagus, for example. Sometimes you might have to use more than one, but still much more conformal than you would see with VMAT. All right, so what we do see is that these patients can survive. Their median survival is around 40 months, and patients do better if they can receive proton radiation. more than just palliative doses with photon, but higher doses, greater than 66 gray, it is possible to treat the heart and have these patients survive. And the toxicities were reasonable. There were no patients that went on to require a pacemaker. There were some patients who who needed a pacemaker after the initial surgery, but we did not see any patient go on to need a new pacemaker. 25% did develop bradycardia, first to second degree heart block. Very, very few with any type of radiation pneumonitis because of lung just didn't have the scatter. And then EF, some on average about 5% or so, like to 10%, range of 5 to 10% change, but no, really, we're not seeing like overt heart failure as a major problem. So very reasonable toxicity. Okay, lastly, I'll cover like how do we actually treat this moving target? You can see here in the movie, it's clearly moving. Particularly, there's two components of respiratory motion and cardiac motion. In our current protocol treating 15 years of treating these patients, to use respiratory gating with double scatter proton beam with an ITV for the cardiac motion. And so we looked at, is it possible is it beneficial to do gated proton for cardiac motion? And so this is a proof of concept study that we just published, looking at, are there certain parts of the heart that would benefit from cardiac gating to either diastole or systole. And so here you can see examples of using proton to treat different parts of a heart, left ventricle free wall during systole versus diastole. And then here treating an example of a right atrial free wall during diastole or during systole. So we basically model different plans. This is an example of a plan for left ventricular free wall target between basically looking at all the different structures using multiple different beam angles, and then seeing which one would optimally decrease the beam angle. And so it turned out that gating is not beneficial in every subsite of the heart. Certain parts of the heart benefit more than others. And so in particular, the left ventricular free wall benefited. The best angle turned out to be either here directly, LAO, or here in the kind of LPO, and if we had to treat the left ventricle. So this is modeling it more for like an ablation. We've only very occasionally needed to treat a cardiac sarcoma target of the size. But if you were to do actual ablation, it would be actually probably a smaller target. But nonetheless, we wanted to see like what is the benefit for gating, and there was a significant reduction, 36% reduction in mean heart dose, and then a 35% mean left ventricle dose with gating to systole as opposed to diastole. The right atrium benefit from gating, a bit of a typo there, so right atrial free wall benefited. Then we went on to look at, like, is it possible to take the current respiratory trigger and actually add a cardiac trigger? Like, is it possible to have double gating? This has not been tested in patients, so this was just a proof of concept where we inputted ECG signal and RPM, a modeled respiratory trigger, and then the signal is then sent to the ion source. And so we look to see, with different cardiac rate and respiratory rate, like what. Is it possible to double gate? And here, I'll just show you. So it does take some time to, because of the duty cycle, so the amount of time that the cardiac cycle is in the phase that you want, diastole, for example, and the the respiratory phase that you want. So with breath hold, you can get there much faster. But with both, it took up to about 45 minutes to deliver 1 gray. So this eventually double gating will likely require a much faster dose rate. So I think working out the technique for cardiac gating may be beneficial for treating the left ventricle from our modeling, or potentially treating some targets in the atrium, but that really awaits further study. All right, so I'll end here. I'll just want to acknowledge my cardiac proton team and my cardiothoracic surgery team and the proton engineers for these studies and for hopefully many other fruitful studies. We are looking to open a proton-based protocol in the Mayo Clinic. So a lot of those early studies were at Heidelberg were conducted by Dr. Douglas Packer, a very well-known electrophysiologist, and he is starting a multi-center trial based out of Mayo. And so, around the world, there are more and more of these studies. I highly encourage you to consider learn more about this potential new indication for radiation. Thank you. I'll pause and take questions. Thank you. Yes.
Hi, I'm Jennifer from National Taiwan University Hospital. Thank you, YenLin, for giving us so much, so great talk. I have been treated for refractory VT using SBRT by photon for like 15 patients in our institute. And and the paper you have shown that, and in the right door down, that is our data.
Oh,
yeah.
wonderful.
Yes.
Yes.
Thank you very much.
Thank you.
Yeah, but I'm wondering that because in National Taiwan University now we are having proton right now. So can you give us any experience like using a proton to treat heart? So do you concern about the skin toxicity, or do you concern about the spine toxicity, or esophagus, or what is the most concern that when you're using the proton to treat the heart?
Good question. So congratulations for for starting your program, because we're kind of proton focused. We're actually still to start, but hopefully soon. And then as far as the question of what are the main concerns, so with proton, if you're treating a left ventricle target, and the target would certainly be smaller than what we modeled in the example I showed. Your main concern is probably going to be esophagus, medially. As you get closer to, and then you've got, mitral valve there. I think, there's probably going to be some lung, in the way. And I think we haven't started using gated pencil beam scanning proton. That's still being worked out for something of this complex of a motion. But when we do, I think you'll have some proximal shaping. And I think even in the passive scatter days when we were treating, the cardiac sarcomas with proton, that's involving the more posterior pulmonary vein or left ventricle free wall, you would typically try to use like 1 or 2 beams, perhaps rather than just single one, and you can use compensator to get a bit of skin sparing. But yes, there probably will still be some visible, I imagine, some changes. Pencil beam will improve that. But I think esophagus is going to be probably the most challenging, and it actually remains the main problem for moving forward in most of the kind of AF, atrial fibrillation, which is another potentially even much bigger larger number of patients who may benefit by the esophagus, depending on what pulmonary artery segment you might be treating. That's probably the most dose limiting. So even with proton, it's going to be a little bit challenging to squeeze that dose in. So my longest surviving cardiac sarcoma patient, 14 years out, had a pulmonary vein sarcoma that we treated to 72 gray with chemo, and did require 1 dilation, but still 14 years out, doing well. But that's with 72 gray in 1.8 gray per fraction. So if you imagine like a 25 gray. So what I was going to say is that it's some of the new basic science translational finding that you might not need as high doses, or perhaps what you're looking for is not frank fibrosis, dense fibrosis, that perhaps lower doses could, durability remains to be tested. But if there are sufficient effect with lower doses, that may help with these toxicity. Yeah. But I think the biggest potential benefit of proton is a reduced dose. One other thing I would just mention is that because these patients already have ICD, that is a potential, currently what we generally do is, unless a patient absolutely needs protons for our photon patients are very strict monitoring parameters for someone with a pacemaker, and it's extremely strict for proton. So the only patients we've ever treated in our department for with ICD are the thoracic, like a lung patient, or usually to try to find if we could do photon instead. But the cardiac sarcoma patients, I've had 3 patients go through and with pacemaker in that were not completely dependent, but kind of borderline to not dependent. But all 3 went through without any complications to a pacemaker with careful monitoring. So there weren't any untoward effect, but we need more experience with that because these patients will come already with an ICD, and so what to do with that with proton is going to be an important thing we work out.
Do you have your protocol like when patients have ICDs and you are going to treat them with proton? And do you have your protocol like the dose to the ICD? We have to threshold to lower dose or which?
So we don't ever go through the ICD. So basically we pick all directions to avoid it. Or often these patients, we will know about them. Well, I'm talking about like the cardiac sarcoma patients, but I think, I suppose one possibility in the future is the ICD placement, so that it doesn't become a potential barrier. Generally, we're going to be going through the back, so it probably won't be as much of a problem. So it's a matter then of potential scatter, but having them in their various locations, down the waist or contralateral side, or so there's different positioning that may need to be.
Judiciously select the proton beam pathway.
Beam direction, exactly.
And you also say that to change the ICD's position by the cardiologist?
I see. So we haven't had to do that. That being said, our experience is with these cardiac sarcoma patients, and 2 of them actually, they were very intentional placement of the ICD so that they wouldn't create a problem. So we kind of knew about their need for proton. So, but yes, you're right. A lot of the VT patients will come to us already with an ICD in, and I think that's probably requires a teamwork with a cardiologist. And if that is something that you will have a protocol for, the placement, optimal placement of that, such that it minimizes the potential for interference with the best, protocol, like proton beam pathway.
Thank you very much.
And
just like for the proton, do you for the proton plan? So do you mention the mitral? Do you calculate the valve, or do you just like to lower dose to the valve, the mitral valve, the aortic valve, something?
Yes. So we do try to create like an integral or PRV for all these structures, also using the cardiac CT, so we have a better sense. I think one could become even more nuanced because not all of the structures are spending all the time, equal time between systole and diastole. So there's really it may be like systole, like in diastole for a long time, and then systole for a brief moment. So certainly it has to be more nuanced. But what we've been doing so far is integral, like a PRV volume that encompasses the cardiac motion, and try to minimize that as much as we can. Yeah.
Thank you very much.
You're welcome. You're welcome. Okay. Time? Okay. Thank you.